topic, which is vestibular. I believe most of us working in a private hearing aid center, so probably doing a vestibular assessment or management or even a vestibular clinic setting will be something that's not so familiar to us, but it's okay. We have a very good two speakers today to share with us about the vestibular clinic setting and also the assessment and also probably some case study so we can learn from it. Of course, if you have any questions or any comments, feel free to type in the chat because we want to initiate discussions among the professional, among the audiologists. So without taking too much time, so I will launch a poll. So probably just let us to know what do you think about the vestibular clinic? What would be your interest? Are you interested to start a vestibular clinic? So you can just let us know the answer. Okay, so here we go. We have 2 questions here, so you can choose. Okay, we are getting more response. Oh, seems like there are some of the audiologists also conduct vestibular assessment or rehab. I personally think this is a very interesting topic because after graduated from the university, probably we don't really get a chance to do those like a VHIT and then like a CVAM or OVAM, those kind of tests. Probably not, we don't really have the opportunity, right? So probably we can learn something from today's sessions. Okay, let's see. Wow, surprisingly, we have like 11 out of 11 who voted. They are interested to have a vestibular assessment or rehabilitation in their clinic. I think this is good though, because we also see patients complaining like a vestibular disease or any kind of symptom. So sometimes we are not sure who we should refer. So probably we can think about it again. Are we going to do it in our clinic or not? Okay, so we will wait for another probably 30 seconds. We will see. Hopefully there'll be more response. Okay, we have another response here. Okay, so let's end our polling and I will share you the results. Wow, we have we have 4 members here. We have around 8 of us. We didn't practice. Let's welcome our first speaker, Mr. Shafiq. So he will be sharing with us about the setting of a vestibular clinic. So let's welcome Mr. Shafiq. Are you ready, Mr. Shafiq?
Hi, I'm ready. So let me on my camera.
Okay, sure. Please take over the session.
Okay, hi, everyone. Thanks to the moderator and the team to organize this kind of session. So for today, the first part, we will talk about how to set up vestibular clinic. So I will share I break down into 4 components or 4 phases how to set up a vestibular clinic. So before I go further, this is just my personal opinion and also my experience, my working experience as an audiologist for clinical support. So I just share to you guys, I believe there will be maybe another approach, maybe you have other comments or any ideas, you just throw in the chat box or you just switch on your mic, just talk because this is a discussion. I think there is no right or wrong on how can we set up this vestibular clinic. It depends on your creativity also. It depends on your strength, your direction. And then there's a lot of factor actually contribute on this vestibular clinic. Okay, so I will start. Eh, okay, so we will talk about this topic, how to set up vestibular clinic. So I break down into four phases, which is phase one, phase two, phase three, and phase four. So I hopefully this is a interesting formula for you guys to start or to plan or to start to plan to set up a clinic. So we will go through phase by phase, and hopefully maybe in your hospital or in your center, you will start to think, okay, I need to start at least at phase one. And then after I complete phase one, then I will proceed with phase two, followed by phase three and phase four. I believe there will be more phase because we will keep learning new things every day. We will get new things, new research, new development. So it will be a long story for vestibular clinic. So for the first phase, uh, this is I believe this is the crucial phase, which is of course we need knowledge. So we need vestibular knowledge, we need balanced knowledge or any related knowledge uh, 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 for this area, for example. So for knowledge, actually we can do a self-learning, we can read all the textbook, we can join international or local webinar, audiology online, and you can attend any special course offered by some of the university, I believe, if I'm not mistaken, UKM also provide special course to the professionals. They have different package, so you can join that kind of course to enhance or to empower your team or even yourself on this area. And then you can join maybe special interest group, maybe for audiologists or any related professionals macam physiotherapists, maybe ENT, neurologists, or even maybe ophthalmologists or optometrists. So this is all the professions that actually related to this area. And then of course we need interest. So everything we do in our daily life, of course we have interest and passion. So I believe we apply these two things in our daily life. Let's say if you want to play, let's say football, then of course we need to love that sports. We will deep dive into that football, for example. So this is all interest and passion. So when we have all these three components here, so I believe it will drive us to another phase. Okay. uh, okay, so phase two. So we when we have all these the first phase, we knowledge, passion, and interest, then I believe we can look for the opportunity that actually available around us, or maybe in your hospital, or maybe in your center, or maybe in your market, for example. Maybe in Selangor is different, maybe in Utara a bit different, and maybe other countries also have different demand, for example. So we can start to look for the opportunity. Let's say in your hospitals, of course you have a patient every day, or even your customer, so you can see the patient flow. So from there you guys boleh tengok, okay, I got a lot of hearing aid case, for example, or maybe I have a lot of patient with middle ear infection, or maybe menial disease, or any vestibular pathology, for example. So we can see the market or the demand on that, which is our opportunity actually. And then we can also look for our team strength, for example. For example, in the hospitals, of course you have different department, different professionals working together. So you can discuss with them. You can like do a survey. Okay, what department that actually available in this hospital, my colleague. So let's say if you have ENT, you have neurologists maybe. So this is few professionals that can help you for vestibular clinic. And then also physiotherapists and maybe nurses, even nurses also. And then you need to do some sort of research, especially on the evidence-based research. So you can have a look on the latest research, what's happening in Malaysia, for example, maybe any prevalence for common vestibular disorder that we have in Malaysia, for example. So actually, there's a lot of research. For example, actually, in 2007, if I'm not mistaken, in Malaysia, they one of the university conduct vestibular research on the prevalence of BPPV. So they found out that uh, approximately 50% of the cases of BPPV is reported in older adults. So maybe from this particular research, so you get the idea. Oh, so maybe older adults have more high possibility to get BPPV, for example. That kind of idea. So we can narrow down the idea from all this opportunity. And then no I in team. I think this is English idiom. So it means we will work in multidisciplinary team approach. We will use this kind of approach, which is we will work together with other professionals. Which is I believe with this approach we can provide a holistic solution to our patient, especially. So I have one experience with one of hospitals. They do consultation to the patient after all the assessment, all the treatment. They sit together in one room. So on that session ada audiologist, ada ENT. So these two professionals do the consultation at the same time. Then they cover different
Oh.
area of the consultation tu lah. So I believe this is the we can call it holistic solution. Uh, and then maybe some of you just wonder, oh, what is their role? What's the neurologist role? What ENT will do in vestibular clinic? Maybe of ophthalmologists. What's their role actually in vestibular clinic? So um, to answer these questions, maybe we can go to the basic knowledge on vestibular itself or the system. So our vestibular, our balance system actually consists of few sensory input, which is vestibular, vision, and somatosensory. So or somatosensation, if I'm not mistaken. So vestibular is more common in within audiologists maybe and ENT, and then vision pun actually contribute to our balance system. So vision most of the time optometrists or ophthalmologists will are more interested on this. And then about somatosensation, I think neurologists are more interested on this, maybe there's a patient came to their clinic and report numbness at any part of their body, dizziness, vertigo, all these things. So it actually is an indicator for them, or this is maybe related to any possible vestibular disorder. So that's why, and then before I forgot physiotherapists also. So they normally in Malaysia they involve more on rehab. So we have different approach on the rehab, depends on the case and depends on the pathology and the management. So physiotherapists also play important roles in vestibular clinic, I believe. And then we also need to develop our own protocol. So before we propose anything to the management, I believe we need to have our own protocol. So any goals. So in the protocols, actually there's a lot of things that mentioned in the protocol. So I just explain few things. For example, maybe you can define your define your service maybe. So you are focusing on which part, maybe screening only, or diagnostic, or maybe rehab, or maybe yang paling best is the whole thing. I mean, all in under one roof, which is screening. You can provide screening, you can provide diagnostic. Maybe it depends on the case, and maybe it is better if you have the rehab service in your center or in your hospitals. Let's say if audiologist not available to do the rehab, then just work together with other department or other professionals to deliver this kind of service. So, and then your target age group, for example, maybe you want to focus more on adult or maybe pediatric. So I believe the settings also quite similar but a little bit different. Same goes to our, let's say kalau kita nak set up audiometry test, then we need to consider all these things macam age, target age group, because the setup will be different, or maybe the equipment will be different, the approach also will be different. And then your test battery. So as you know, vestibular assessment is a when I during my school, I saw the lecture notes. Oh my God, there's a lot of assessment for balance, and actually we need our clinical judgment, our skills, experience to decide, okay, which test battery that suitable for this particular test. So that's why you need a protocol. So the protocol or maybe guideline, or you can refer to any guideline that available in the market. Let's say from AAA, double A, maybe BSA, and hopefully maybe we have our own, I mean a Malaysian guideline, or Mansa maybe can come up with a guideline for vestibular assessment or rehab test battery, or for example, that kind of things. And then I think if you have all this point, then you can use this point as a bullet in your proposal. So actually you can submit the proposal to your management, or maybe to your head of department. Maybe normally there will be a step by step, right? Ikut level tu kan. So maybe you can propose to your head of department, and then management, or maybe marketing team, for example. So I believe with this all this point, you can include in your proposal to show that there is a value for us to have a vestibular clinic. Okay, and then after we propose the proposal, then of course we want to know the result, right? So it depends. Sometimes it depends on the management also, and depends on how you deliver the proposal. Also is a apa orang cakap, is a crucial actually lah for the decision. So I hope that all the point I mentioned before can be a very effective bullets in your proposal, or maybe on your presentation for this first phase 1 and phase 2. And then okay, so for the first phase 3, let's say if the management agree on the proposal and they're willing to spend, so it's a good news for everyone, especially for your department. So I think that one will be considered straightforward. Then you can run your clinic as usual. But what if the management agree with the proposal, but and agree to expand the service, but they really don't have any budget to buy any equipment for vestibular clinic, or to spend a lot of money for this particular plan. So for me, I don't see this is a problem, but actually it's a challenge for us, for the audiologist maybe. So maybe your team still boleh deliver the service of vestibular, but maybe without equipment. So I think most of us macam our mindset is, okay, to do vestibular assessment, we need equipment. To do vestibular rehab, we need the foam, the plate, for example, all that kind of equipment is a compulsory. But actually, there's options for you to do the assessment or rehab without equipment. But please bear in mind there will be certain limitation if you do assessment or rehabilitation without the equipment. So if you are aware on this limitation, then I think you are good to go to do the assessment or rehabilitation without the equipment. So for example, maybe for assessment macam head impulse test HIT. So actually we can do it without equipment. So kita still we will turn the patient head at certain degree or angle, and we will monitor the eyes movement, or we call it a saccade, using our naked eyes. But there's some limitation. So some of the limitation will be uh, maybe you can detect the overt saccade, which is the eyes movement after the head movement. I think that one should be easier to catch that information using our naked eyes. But there's a quite challenging to detect covert saccade. I mean the eyes movement during the head movement. So it's quite challenging, I believe, using our naked eyes. So that's why the equipment will come in to assist us to get more information and to have more reliable and more accurate result. Okay, and then I think apa lagi test yang ada? For example, smooth pursuit, for example. So smooth pursuit, we need kind of macam stimulus. So normally without equipment, you can use maybe like a simple pen macam ni, this pen. Then you can move from right to left with certain velocity, with certain speed. So the patient will focus on the stimulus or this pen. So we will monitor the eyes movement, how their vestibular system react with that stimulus. So still same. We will use our naked eyes to catch that information. But there's some limitation, which is especially on the stimulus. So maybe I will move the pen with this speed, for example, and maybe our lovely moderator will move the pen faster, maybe, or slower. So it will be variation of parameter or speed in terms of the stimulus. So we can't control that parameter without equipment, unless if you have unless you control certain factors, for example. Okay, that one for more on assessment. And then I think treatment or rehabilitation also you can do without equipment. For example, let's say BPPV, for example. That's the common case in common case. For example, let's say posterior BPPV, then we can apply Apley maneuver for the treatment. I mean to place the otoconia back to the original place in the otolid part, otolid area. And then we have I think barbecue maneuver for lateral BPPV. So this maneuver require no equipment to do this. And then I think for postography, we have all the foam. Even without foam also, you can do the rehabilitations. It depends on what activity that you do for your rehabilitation. So actually you can start the assessment or rehabilitation in your clinic without the equipment. Even the management are not willing to spend to buy the equipment. So rather than kita tak start or just the proposals just put on in the cabinet, why not you initiate the plan, even with all the difficulty, with all the challenge. You just start maybe 1 or 2 patients for a week, or maybe in 1 month you have 5 to 10 patients. You just do without the equipment, and of course you will have some limitation and challenge, then you need to discuss with other professionals or within your team on how can we provide a holistic solution for this particular case, for example. So in the meantime, you can sharpen your skills and knowledge. So because you experience, you meet case every day, or maybe one case for a week, for example, but at least daripada tak ada, for example, kan. So you will experience by yourself, and from that experience with your knowledge, and you can improve your skills also. So tak semestinya tak ada equipment, then you cannot do vestibular assessment or rehabilitation. And then also in the meantime, bila you buat all these tests, you also can create the demand within your hospitals, maybe, or kalau paling best you can inform other hospitals to refer to you. So with this all information, you can increase the referral rate to your hospitals. So for example, in your hospital itself, let's say ada neurologist, ataupun ada maybe in ENT, even in ENT ada ophthalmologist. So you can maybe do some presentation, or maybe you just share some research or any reading materials related to this area. So to convince that, okay, we can do this, there's a demand, and we can survive with these things. Okay, and then this is I think after we complete the phase 3, and then we can proceed with the phase 4. So after you have all the demand, all the support from your team, from other departments, from other professionals, or maybe from other hospitals, or maybe your old friends, or maybe you who refer all these things. So you have a very nice patient flow, very nice demand for that particular service. So we hope that that kind of outcome at the end of the day. And then, so actually you already have all these bullets, and then we can propose to the management on to have equipment, because of course we have all the demand, and we have all the points that can propose to the management. We already do this in the clinic. We have this outcome. We have this example of the case, and then maybe other professional like neurologists then can support us to share on this case, and actually this case is successful. So this is all the success story that we have before, maybe last few months or last year, for example, that can be used for another proposal to buy the equipment, or to have equipment, or better vestibular clinic setup for your clinic.
Thank you, Mr. Shafiq.
Yep.
Yeah, so we actually have a questions from I think Mr. Jensen. And so he's saying that the ENT is already doing balance testing. Why would he or she wants to refer to audiologist for testing? Would you like to answer the questions now, or you would like to keep it for the Q&A?
I think keep it for Q&A.
Okay, sure. Thank you so much, Mr. Shafiq.
Mm-hmm. And I think this
So,
is last part.
yes, sure.
Last part. Actually, there's a maybe you can have a more reading on this, because that not only in audiology department or ENT department, we also can talk to emergency department, for example. So actually there's a nice reading or research on this, because in emergency department there's a certain case that related with vestibular neuritis, stroke. So we are interested on to differentiate. Oh, so this is VN case, or maybe this is stroke case. So let's say if we can come out with a proper diagnostic, then why not we can deliver early management for this kind of case, for example. So instead of diagnostic, actually vestibular also can be a screening tools in emergency department. And then maybe in CI case, some of the hospitals started to do pre and post vestibular assessment for CI. So this is of all the potential collaboration with other departments that we can expand the clinic. Yep. So I think that's all for me.
Yeah. Thank you so much, Mr. Shafiq. So we really enjoy your sharing. I think it kind of inspired me also. So we would like to invite the next speaker, which is Miss Darleena Hold on, yeah. So Miss Darleena, are you ready for the coming sessions? It's your turn to share with us about your experience in doing vestibular assessment and also some of the case study. Are you ready, Miss Darleena? She's from Prince Court Medical Center. Hi, Miss Darleena. Welcome.
Hello. Hi. Okay. Sorry. Okay. Now, bear with me. I'm not an IT expert, so let's see whether I could do this. Well, anyway. Good afternoon, everyone. I'll just be talking a little bit about vestibular assessment as well as I'll be sharing two case studies. You know, Shafiq mentioned just now about oh, sorry. Where is it? Just give me a moment. All right. Can you see these slides, everybody?
Yes, we can see. Yes, we can see your slides.
Okay, but just to capture just now, Shafiq was mentioning about, performing assessment to differentiate, when you could screen certain cases like stroke cases. We actually had a case of stroke. So I had initially thought of sharing that case today, but I think time is a little bit short. So I'm just going to share two cases of multiple sclerosis as well as just vestibular neuritis. All right. Okay. All right. So yes, I'm attached to Prince Court for the past 13 years. So venturing to vestibular quite recently, I would say about 5 years. Still a lot to learn. Only now venturing into assessing pediatrics as well. Okay, seriously, sorry. I'm not used to giving talks about these webinars. I'm more old school. So hang on. I can't see people, so it's a bit weird giving talks in this way. Okay, now I kind of like this slide from Vida, because when we talk about balance, you're actually touching on three systems, which is the inner ear. That's where we normally perform the assessment, the vestibular, visual, as well as proprioception. Now, when we talk about diagnosis, it has always been an issue because we've had cases where patients have gone several places. We're not getting a proper diagnosis because it's not a proper setup, to the point that we had a case a year back where this young lady had gone to about 5 or 6 different centers, not given a proper diagnosis, and was even diagnosed as having a psychological issue. When in true fact, when she came here and we did the assessment, it was found to be, she had vestibular hypofunction for both sides. So chances are she had vestibular neuritis, but it was captured later. So it's more for vestibular rehab. So I think Shafi also mentioned that when we talk about vertigo or dizziness, in terms of the management, it involves not just one person, it involves a team. So physiotherapists, ENTs, neurologists, and the list goes on depending on the team that you'd like to have. Now let's go down to when we talk about vestibular assessment. Okay, sorry. Okay, sorry about that. Now, when we talk about vestibular assessment, it's actually looking at the vestibular apparatus. So I normally tell patients
no problem,
that—
Miss Darleena.
I'm so not good with all these webinars. Shafiq is a pro looking at the way he's talking just now. Now, when we talk about vestibular assessment, we're looking at the vestibular apparatus. So we're actually looking into the 5 different units. So basically 5 different units in each ear. So it's like 3 semicircular canals, which is here. Okay. And you've got the otolith organs, which is the utricle and saccule. So the test that we have is actually testing this whole apparatus. So we've got video head impulse test, ocular VAMs, vestibular evoked myogenic potentials, and also cervical VAMs. So each of these tests will be testing different parts of the vestibular apparatus. I do know that, calorics is still the gold standard for some, for most, but moving forward, when we talk about calorics, it's actually testing the lateral canals. So it doesn't really capture all the units inside the vestibular apparatus. So we do need all these other tests to complement the test itself. And calorics is it's actually more low frequency. Whereas if you look at video head impulse test, it's higher frequencies. And if you look at rotary chair, it's actually in the mid frequencies. Now, let's just go through each. When we talk about ocular VAMs, it's actually testing a linear acceleration, which is more of the horizontal movement. So sometimes when we ask patients, when you're inside the moving car, does it trigger any episode? So that's actually trying to relate basically to the utricle. So the test that we do is actually ocular VAMs. So OVAMs provides information in terms of the utricle as well as the superior nerve of your vestibular system. Whereas cervical VAMs is also looking at linear acceleration, but it's more vertical movements. So sometimes we ask patients, like, do you have problems like, when you take the elevator or taking the stairs, does it trigger any episode? So that gives an information in terms of the saccule. Now, cervical VAMs, apart from providing information of the saccule, it also provides information for the posterior nerve in your vestibular system. So combine that with the video head impulse test, it looks more in terms of torsional movement, your head movement. So you've got the superior, posterior, as well as the lateral canals. It's also like for the superior as well as the lateral canals is also innervated by the superior nerve, whereas the posterior canals is innervated by the inferior nerve. So combine all this, you basically have, you're able to piece the puzzles in terms of where the problem lies. So if, let's say, it's positive we hit, for example, at lateral canals, as well as positive at OVAMs, so that gives you an idea that there's a problem at the lateral canals, as well as the utricle and superior nerve. So that gives you an idea that it might be a vestibular neuritis, as compared to just like negative hit, but positive OVAMs. So that most probably is a utricle problem. So when we talk about vestibular assessment, it's trying to put the puzzles together. So it's not just simply performing all these tasks, it's also to combine the results for us to come up with an idea where the pathology lies, and because this will influence our management. Now, apart from all these tests, of course, we have VNG, which looks at calorics as well as oculomotor. So oculomotor gives you more information all the way to the cerebellum. So it's more central. So again, like I said, put the pieces together and you can have the whole idea whether it's a peripheral problem or a central problem, or it could be both, which is very rare. Now, before we proceed with any assessment, the most important part that sometimes I feel that as clinicians we tend to miss is we jump straight away to the assessment. When in fact you need to ask the case history, because this will give you an idea in terms of the problems that the patient is facing. So like, for example, when did the problem start? And whether it's a true vertigo, meaning whether it's objective or subjective. What is objective or subjective? It's basically, does the patient feels that he or she is spinning, or the room is spinning? So if it's the individual feel that he or she is spinning, that's more objective, whereas subjective if they feel that the room is spinning. So because most of the time when patients come, they claim that they have vertigo, but you have to double check whether it's a spinning sensation or it's just dizziness or imbalance. We've got some situations where they call multi-debugment, where they feel that they're floating. It's like stepping down from a ship, for example, the floating sensation. So that is not considered a true vertigo. So the reason that we ask all these questions, because apart from the test results that we're going to give, we're going to combine with the case history, because this will give you an idea, for example, whether it's vestibular neuritis, multiple sclerosis, vestibular migraine, and so forth. Now, the other most important part is to know the duration of episodes, whether it's seconds, minutes, hours, or even days. Okay, because like, for example, if it's BPPV, usually the vertigo symptoms is only within seconds to minutes. Okay, whereas for menials, it could be hours. And for vestibular neuritis, it could be more, it's hours and sometimes even days. Now, how bad is it? Does it cause any nausea? Does it cause any vomiting? And any positional head movement, does it trigger any episodes? Because this usually relates to BPPV. Now, of course, you always need to ask whether there's any hearing loss. Because if yes, when did it start? Does it fluctuate? Is there any tinnitus or oral fullness? Because based on this, we would be able to distinguish whether it's neuritis or labyrinthitis, or even for Meniere's disease. Because if you look at Meniere's disease as well as vestibular migraine, the symptoms can sometimes be a little bit similar. But what differentiates between the two is usually the hearing loss. Okay, so you can see the pattern, it fluctuates, it affects more the lower frequencies and so forth. Tolerance to loud sounds. Why do we need to ask this question? Basically, is to determine whether the patient has any dehiscence. Okay, so because if you have dehiscence, usually he or she would not be able to tolerate loud sounds. So the next is to ask whether vertical and horizontal, sorry, there's a typo there, horizontal movements, whether they have a problem, because it's to give us an idea whether the saccule or utricle is actually involved. Ataxia mostly is a central pathology. So that's, well, you could observe it yourself, whether the patient has a gait when he or she walks. So that gives you an idea whether, it's more peripheral or it's more central pathology. Now, this is the recommended workflow from AAA. Okay, you could it's not necessary to follow this workflow. You could develop your own workflow, because I find that most centers, if you look at, because ENTs, they still stress that they insist on having calorics as the basics, which is fine, or even rotary chair. But you have to understand that sometimes it's a little bit expensive. And the thing that I find myself not really a fan of calorics is the effect on patients, because if you are normal and when you do calorics, it would cause some form of dizziness to patients. So I'm not saying you shouldn't do it. I mean, if it will be good to have an extensive setup, especially for medical legal case, because calorics will give an idea if a patient has Meniere's disease, as well as the fact that it gives us information in terms of the low frequency. Now, this is the workflow recommended by AAA. Of course, like I said, case history. Now, do not forget physical examination, because sometimes I think as audiologists, because I know we are so excited about having all these tests in our hands, all these gadgets of VAMs, VHITs, and all the other tests, VNG, to the point that we forget to do simple bedside tests. Okay, so there are centers where the ENT has done it. So like in our place, like for example, like the ENTs, when they refer the cases to us, they would have done Dix-Hallpike, Romberg, Unterberger, or Fukuda. And so there are also ENTs who did not do any of these tests. So always do it, because any additional information is very helpful in terms of coming up with a diagnosis, because it will definitely influence in terms of the management. Now, do you suspect BPPV? If yes, then do perform Dix-Hallpike. How do you suspect BPPV? Like I said, go back to your case history. If it's true vertigo within seconds or minutes, it's triggered by any specific head movements, then usually we would suspect BPPV. So perform a Dix-Hallpike, and from there you would know if it's positive, then you would do the subsequent maneuvers which is related to it. If no, then you proceed to do a spontaneous case. Look for any signs of nystagmus, head impulse test. Okay, you can do a head impulse test without video head impulse, meaning that you do a head impulse test yourself. But of course, I think Shafiq did mention that you would only be able to capture overt saccades or not covert saccades. So that's where VHIT comes into the picture. Now, do VAMs. I would implore that any clinicians, if you start to do VAMs, try to do both CVAMs and OVAMs, because missing one, you're gonna miss some information. Okay. Hearing exam, do not forget to do the hearing exam. Over here, that's the first thing that we do. Meaning when you do hearing exam is your audiometry, your middle ear assessment, meaning it includes tympanometry as well as reflexes and even decay. Okay. Now, this should basically give us an idea in terms of the peripheral assessment. Now, if you suspect that the patient has Meniere's, so the add-on test will be caloric score. ECOG, and or. So depends. Now, if there's anybody who disagrees with my with anything that I say today, feel free to discuss later. Now, this is the recommended if you suspect vestibular neuritis. So case history, physical examination, look for spontaneous nystagmus, head impulse test, VAMS, meaning both CVAMS and OVAMS, because you need to know in terms of the superior and inferior nerve. Because if you were to do CVAMS, you're going to miss the superior nerve from OVAMS. So the add-on assessment will be calorics. Now, if you suspect Meniere's, the same thing, with the exception of adding on ECOG. Now, these are samples of different VHIT equipments. If you look at the goggles, like different those two up here, this uses goggles as well as this one, and this is without goggles, which is usually it's the one that we have here. And the reason that we purchased this particular device is because I'm doing both for adults as well as children. So for children, we can't really use goggles because it's kind of difficult to put goggles on children, and in terms of the size will not be suitable, especially like an 8-month-old baby or even a 1-year-old baby. If there's slippage, it's going to affect the results of the test. But if you're doing only adults, by all means, go for the goggles. But like I said, because our setup is more doing for both, for adults as well as children, so we need to use the one that is suitable for both. Unless I have additional budget, then for sure I look for another one with goggles. All right. Now, let's see, how much time do I have? Because I need to discuss cases. So I'll just skim through so that I think some of you are aware of what VHIT is all about. So basically, what's the advantage of VHIT?
Yes, sure, Ms. Darleena. You can still have another 5 minutes to go through.
Oh, 5 minutes? Okay,
yes.
not enough time.
Is it enough for you, or would you like to take a bit longer? Not enough time. Okay, just try your best if you want to take a bit more time, because I believe people also would like to learn about a case history, case study. I think that part is interesting.
Okay, all right. So in terms of video heat impulse test, I guess the advantage over all the other tests is it assesses all the 6 semicircular canals separately. It's a high frequency assessment. You have to remember that. So previously, in terms of whether calorics or even rotary chair, it only assessed the lateral canals, but it doesn't give us any information in terms of the superior or even posterior canals. Now, it's relatively easy to perform the test, okay, and it can even be performed on patients who are, you can even perform it in the wards, for example, but of course I wouldn't advise it because we don't really want to move the equipments too much, and it's easily accepted by patients, meaning that it's not invasive and it's not painful. It's relatively fast actually. If you're good at it, it's just about 5, not more than 10 minutes actually, if you're good at it. And most of the time, we don't really have much problems in terms of doing it on patients. Now, these are the samples. You could see the saccades there. Now, let's just skim through in terms of VAMS. So VAMS is divided into OVAMS and CVAMS. So for OVAMS, in terms of when you stimulate the utricle, it induces short latency responses at the eye muscles. This is why you notice that we have to put electrodes at the eyes. Okay, whereas if you stimulate via sounds in the saccule, sounds which are loud enough to stimulate the saccule, it will induce a short latency responses at the neck here, at your neck muscle. So this is where cervical VAMS comes into the picture. So looking at the evidence, VAMS are now being clinically used to assess otolith functions, and it's also been current research on the utility. You're looking at screening tool for semicircular canal dehiscence, because if you get really low thresholds, that indicates probability of SSCD. It has also been studied to use in terms to detect multiple sclerosis, looking at the delayed latencies, which is a case that I'm going to share later, as well as CVAMS to detect Meniere's disease. Okay, now for Meniere's disease, you need to change the frequencies. Currently, I'm sure most of us are using we are using 500 Hertz tone bursts. If you can't get clear waves, you could switch to 750 Hertz. But there are doing research, I think Shafiq could help me out later. In terms of research, you're doing looking into means and you're differentiating, and you're doing at 500 at 1000 hertz and looking at the patterns in terms of the amplitudes. So it's an ongoing research. But one of the papers that I write is a little bit odd in the sense that I'm looking at the EMG, the muscle, the neck muscle. It is to me is considered really high. So I'm not really sure why they set it at 50 to 200 microvolts. Okay. So anyway, we'll discuss that maybe in some other time. Now, just an example how cervical vamps are done. Okay, if you look here, these are the electrodes at the neck. So you introduce sounds here, and we look at the readings from here. If this is actually trying to look at the EMG, the neck muscles. Okay. Okay, just need to stretch the muscle, and we look at the reading. I'm just going to skip this. So need to look here. Okay, because again, it depends on different equipment. Okay, so you would have different settings. So you need to stretch the muscles within this green area, and it should not be below, or you won't get accurate results. Or if it's too high, you're going to get really high amplitudes, and that could be also misleading. Okay, OVAMs, electrodes underneath the eye. Some uses here. Okay, but a method that I learned in France is actually you place the electrodes similar to the ones for CVAMs in terms of, at the clavicle, right? You just switch the ground. So meaning that if it's for CVAMs, the ground is placed here, whereas for OVAMs, we switch it to clavicle, and the other one goes up. Okay, but again, depends on your setup. So that was just a method that I learned during my attachment. Okay, now. So what do? We ask patient to look at the specific target above, okay, to stretch. Okay, that's not a good thing because she blinked. Okay, so as much as possible, you need to inform patients not to blink, or else it's going to affect the test results. Okay, this is an example of the waves that you'll get. Okay, now, okay, Ichu, am I good on time?
Yes, sure, Miss Darleena. Don't worry, you can continue. So for those audience that if you have any other things to do, then you are feel free to leave later. No problem. Please continue, Miss Darleena. It's very interesting.
Okay, great.
Thank you.
Fine. You're welcome. Okay, now the first case is a 32-year-old female Caucasian. The onset of symptoms was actually 10 months earlier. She reported having true vertigo, and it was not induced by any specific head movements. In terms of duration, it was in minutes, meaning the periods of duration was minutes in terms of the true vertigo. The periods of compensation was was several days actually, which is indicative of something more significant. However, the interesting part is that there's no nausea and no vomiting. Now, after the first symptoms, the latest symptoms was actually, I think, a month before she came to see us, was that she no longer has true vertigo, but what she had was actually a sensation of tilting whenever she's sitting down or whenever she wakes up in the morning. And the latest episode was actually triggered when she was looking at the phone, and suddenly she felt off balance as well as tilting. The funny thing was she also reported oral pressure, which was right more as compared to the left, but no tinnitus. So usually oral pressure gives us an idea that it might be Meniere's, but looking at the other reported symptoms doesn't seem to tally. So test results. Okay, when we did the hearing assessment, everything was normal. Her auditory thresholds were normal, her tims were normal, her reflexes were present, ipsilateral as well as contralateral. In terms of the video heat impulse test, we noticed that she had covert saccades for the lateral, as well as the posterior semicircular canals. Gain was normal. Now, the other thing that I sometimes notice with clinicians is that we focus too much on the gain, meaning that I have seen cases that when you get normal gain, and that's it, that's considered normal. Please bear in mind that's not enough, meaning that gain, you can get normal gain, but you need to also look at the presence of covert or overt saccades, because it is still pathological, even though the gain is normal. Ocular vamps, there was nothing, it was normal. Presence of N1 and P1, the latencies, amplitude thresholds were normal. and the asymmetry ratio was also normal. However, when we performed cervical VAMS, the waves P1 and N1 was present bilaterally with normal amplitudes and thresholds, but we noticed that there was a delay in terms of the P1 latencies on the right, as well as delayed latencies for P1 and as well as N1 for the left. Ratio was of course normal because both are actually delayed. For VNG over here, we just perform oculomotor. So the rest was normal. Saccades was normal, smooth pursuit was normal, optokinetic was normal, gaze test was also normal. However, for the smooth pursuit, we noticed that for the vertical smooth pursuit, okay, now again, I know that it is still under research in terms of vertical smooth pursuit because the norms and everything has not been properly established, but we still do it because just to be sure, well, just to give us additional info. But we noticed that the gain for the vertical smooth pursuit was reduced. So click somewhere. So we just, we just wonder if there's something happening further up because any of the oculomotor tests will give us an idea in terms of the pathology all the way to the cerebellum. And when you look at the posturography, because we look at the risk of fall, so all patients who undergo assessment in our center will need to do a risk of fall assessment using vertigut posturography, and she did have a moderate risk of falls. So let's go one by one. I hope you could see it. If you look at the OVAMs, nothing significant. Okay, I did not include all the data in terms of the latencies and whatnot because crowded sangatlah pun. I pun pening tengok. Anyway, this is normal. The latencies, amplitudes, everything is normal. So nothing significant there. Now let's look at the cervical VAMs. So if you look here, it is kind of okay. Normally, I would advise that you still seek thresholds because I noticed that there are some centers who just perform it maybe at 80, 90, or even 100, and when you got responses, and that's it. I'm not really keen because if you want to rule out SSCD, you need to check for the thresholds. And sometimes the more information that you get, it'll give you more data in terms of the asymmetry ratios, as well as you look at the latencies, whether it tallies in each intensity. Now, if you look here, P1 is significantly delayed. This is, I think, about 18 to 19. But the N1 is actually normal. Now, disregard this because I don't consider, the amplitude was a little bit reduced, so this might not be an acceptable thing. I just wanted to show that sometimes you could get this. Now, if you look here, this is way delayed, okay, because it should be, I think some centers stick to N1323, that's easy as a rough guideline. So you could see here that it's significantly delayed for all. So this was, except for this one, so this is an error actually. So I just wanted to again show you that we can get errors. So usually we repeat the test just to be sure when we get something which is not consistent. So latencies are delayed, especially on the left side. P1 is delayed for the right side. Looking at the V-hit, you've got saccades here. And actually some form of overt saccades as well. There's also saccades here. Okay, as well as here. This is just an error in terms of the eye movement. So sometimes we did not really clean up the data, but again, it was normal. In terms of the risk of falls, there was a 45, where's my cursor? So there's some form of risk of falls here. This is a moderate risk of falls. So meaning that because of the vestibular symptom, because of the vertigo or, of the vertigo, she does have a moderate risk of falls. So based on the test results, because of the delayed latencies and the symptoms and everything, we look at the delayed latencies for CVAMs, and then we look at the V-hit. So usually if it's multiple sclerosis, it will be bilateral. Okay, so you could see that it affected both lateral as well as posterior canals. And there are research suggesting that some of the symptoms of multiple sclerosis is actually a combination of delayed latencies as well as pathological lateral as well as posterior canals, but not necessarily, but somehow she sort of matches that. So we did suspect that she might have multiple sclerosis. So in terms of management, actually when we told her that we suspect that she might have multiple sclerosis, that's when she ventured the info that her mother has MS, which was like, we were actually quite surprised. We did not expect that. So we referred her to the neurologist to rule that out, as well as the physiotherapist, because she did have a problem in the, for her vestibular. So she was referred for vestibular rehab. Now this is the room where we do the VHIT as well as the vertical osteography. Now, so far okay. I'm down to my last case study. You good?
Yes, good. I think I have to go back and read my all the notes. Probably some of the test results that I don't really understand. Yeah, but it's a very good sharing. Thank you, Miss Darleena. I think I've learned a lot.
All right,
Yes.
great. Actually, there are several case studies which was interesting because I had one stroke patient I really wanted to share, but I was afraid of time. But maybe next series where we could share more case studies so that we could share information in terms of what to expect.
Yeah, sure. That would be great.
All right.
Yeah. So thank you so much, Miss Darleena,
So
and also Mr. Shafiq.
Li Chu, I've got one more case study.
Yes.
I've got
Yes,
one more
sure.
case.
You can proceed. No problem. Case 2, no problem.
All right. Okay. Next case is a 24-year-old female. She was born with a congenital hearing loss. Now, this patient was not referred to me for a vestibular assessment. What happened was because we were doing all this vestibular assessment and we were just like saying like, yeah, we offered to her just be a subject for us. And lo and behold, we were taken aback with the results, to be honest. Now, looking at her, she's actually our patient for hearing impairment. So I've seen her since she was a child. So now she's 24. That's how old I am. Anyway, her current level is a moderate to severe sensorineural hearing loss on the right and a moderate sensorineural hearing loss on the left. She's on hearing aids binaurally. After we did the test, then only she offered us all this information, that meaning that she had vertigo episodes way back in 2015 and she was seen by the ENT. However, I'm not sure what test was done, to be honest. She was given beta-6 and that was it. And then when she came for the hearing for the vestibular assessment, she also admitted that she has this tendency to fall, meaning that she actually missed several steps when she was taking the stairs, and there was also reports of oscillopsia. Okay. Now, so based on the test results that we did for video hit impulse test, it was again normal gain. However, there was covert saccades for the lateral canals bilaterally. In terms of cervical vamps, nothing, meaning it's normal. For OVAMs, it's presence of waves N1 and P1 on the right with normal latencies and amplitudes. But having said that, it was the threshold was slightly elevated. So that suggests that it's a pathological utricle and maybe superior nerve. So absence of waves on the left, so definitely a problem at the either utricle or superior nerve. When we did the oculomotor test on her, no abnormalities detected for saccades as well as gaze test. However, for smooth pursuit, it was we got a very low gain. We couldn't do optokinetic. She developed very bad dizziness and nausea. In fact, when we did OVAMs, she was struggling because she had difficulty focusing because of oscillopsia. It took us a long time to manage to get the whole test result. What scared us was the fact when we did vertical osteography, it was a high risk of falls, meaning this girl is a fall case. Dia boleh tumbang je. So we were a little bit taken aback, to be honest. So this is the CVAMs. So everything is normal. So you could see normal amplitudes, normal latencies, normal thresholds. Okay, so no problem there. This was her OVAMs. Now disregard this. Okay, we repeated that. because it doesn't make sense that at higher intensity, the amplitude is lower as compared to a lower intensity. So sometimes I say, blinking, or sometimes, stirring, like, because some patients, when we ask them to stare, and suddenly they open up their eyes like really big and then close it back again. So sometimes it will affect the results. So ask them to look consistently at the target. But if you look here, there's nothing. Okay, so absence of waves P1, N1 and P1. Okay, so this was now there was actually another VHIT results which I can't really find for whatever reason. So anyway, some form of covert saccades here, not really overt because it's just one particular, it's not like really consistent, but the rest everything is normal. So pathological lateral canals, normal gain, but with presence of covert saccades. So this was her risk of false assessment, 85%, meaning that she could not even do most of the tasks that we gave. Okay, so she was a high risk of false case. So we suspected that because of the lateral canals as well as the pathology, as well as the positive OVAMs, it could be a neuritis problem, because meaning that lateral canals, superior nerve, OVAMs, superior nerve, so chances are it's a neuritis. We can't really say it's labyrinthitis because she is she had hearing impairment before, and we did not notice any changes in terms of her hearing levels. So we don't suspect a labyrinthitis, but most probably a neuritis. Referred her to the neurologist, who did some tests. They suspected myasthenia gravis. After the test done, it was negative. We also referred her to the ophthalmologist because of her oscillopsia. And like I told you, she had difficulty performing OVAMs as well as optokinetic tests, oculomotor tests, because of her visual, because it induced really bad dizziness. So she was diagnosed with accommodative spasm. So she was treated for that. We also referred her to the physiotherapist for vestibular rehab. And this is where I wanted to emphasize that it's important to have a multidisciplinary approach, meaning you have to work together with other clinicians. Because after her vestibular rehab, we reassessed her vertigo posturography. It went down to moderate risk of falls. From 85, now it's, I think, about 42, 43. Big difference. Of course, there is still a moderate risk of falls, but from 85 went down to 43, so that's really good. So of course, she would still require further rehab sessions for it to go back to normal, meaning that she's using other sensors to compensate for the problem that she has with her vestibular system. All right, and that's about it. I hope I did not bore everyone. So that's my team. Okay, that's the three of us. Okay, when we were trying to set up the clinic. All right, thank you.
Thank you so much, Ms. Darleena. It's a very good sharing. Okay, so shall we move on to the Q&A sessions, because I see there are a lot of questions coming from the audience. So please allow me to share the slides. Hold on, yeah. Okay. Yes. Can you see the slides now? Can you see the slides?
Yeah.
Yeah, okay, sure. Okay, so we have some questions from the audience. So I hope everyone can see the slides, and let me just conclude for the first three questions. I think it's related to, the role between an audiologist and also physiotherapists and also the doctors, where when should we refer them to other professional? Because as we know that audiologists also doing vestibular rehabilitation and also assessment. So could any of the speaker maybe can share with us your point of view?
Shafiq, you want to go first?
Thank you. So actually, as we mentioned before on the first part, or maybe on Miss Darleena part, everyone have their own roles. We have multidisciplinary team, so that's why we have a team that can play their role for certain objective, for example. So let's say for physio, I'm not sure, but in Malaysia, I can see that in Malaysia, physiotherapists more focusing on rehab, if I'm not mistaken. And then on ENT, they are more focusing on prescribed medication, beta-circ, maybe corticosteroid, for example, that kind of things. They, this is like they like on this approach. And then for audiologists, we are more interested on to rule out or to come up with a possible diagnosis. That's why we have the test battery. That's why maybe some of the ENT they are able to do positional tests, for example, all this whole pipe, but not only this whole pipe to come with a very good or accurate result or the diagnosis. We need other assessment also. Maybe for we need V-heat for peripheral, for example, and even for V-heat also sometimes we cross check with VAM, for example. So all these things we that's why we need a team to provide a holistic solution for that particular case or any case or for your patient. Yep. Mm.
Thank you, Mr. Shafiq. Is there any sharing also from Ms. Darleena? What's your point of view?
To me, it's like, I mean, like over here, how the team works is that like for any suspected vertigo cases, we always go to the ENT first because they need to rule out all the medical condition. Usually what they'll be doing are the bedside tests, for example, like Romberg, Anteberger, even the Dix-Hallpike. And if it requires maneuvers, then they'll be doing it. It's only when, you know, after that has been ruled out and no suspicion of BPPV, that's when you refer the cases to us. So I just want to share because like we had one case before, a Japanese lady went to see the NT, did not perform proper assessment then, was only given the usual. Okay, I agree, Shafiq. Most of the times, ENTs tend to just give beta-circ, Stugeron, and all those things, and it just suppresses symptoms, but it does not really provide in terms of answers to what's causing the problem. So it's later when she came to see me, when we did the test, we found it was vestibular neuritis, but it was too late. Okay, so if the patient was referred to us when she had the symptoms, you know, her vertigo symptoms, and if we did the assessment then, we could have just referred her back and she would have been being administered steroids to restore back her vestibular function. So that's how the team works, meaning that they assess medically and then they refer to us for all the respective vestibular assessment. And based on our findings, that's why you decide the management, whether it needs to be treated medically, meaning like using of steroids, for example, if it's neuritis, or Meniere's, how do you know how do you manage that? Or multiple sclerosis, it goes to the neurologist, and rehab part, it goes to the physiotherapist. Yes, there are audiologists who does perform vestibular rehab. That's fine. But on my part, I would rather, you know, I try not to do all. I would rather focus in terms of performing the diagnostic procedures. And if I were to provide a rehab, it's just to complement the one that the physio does. So like, for example, like Vertigat, apart from being a tool to, for risk of false assessment, it does also provide some form, we can also perform rehab procedures, but only after they have done the vestibular rehab, and that is just to complement the physiotherapist. So
that's why I think the guideline is very, and the protocol is very crucial at this point. So we make a clear cut what is everyone's role, what's the audiologist role, what's the maybe physiotherapist role for the case or for their patient. So I think guideline or protocol should be helped on to answer all these questions also.
Yes, true. So that we are also clear about like what will be our roles and then how we can work together. I think that will be the most important point of the three questions. Thank you so much. So we also have another questions. And when do we need to refer? Okay, sorry. How to diagnose central or peripheral vestibular issue?
Nak jawab kan? Nak jawab?
Yes,
Okay.
just now was in the
Miss
slide.
Darleena,
So we
Miss
use
Darleena.
like, yeah, okay, sure. And what do bedside test? I think it was also mentioned during the session just now. And this one is, do you conduct glycerol test for Meniere disease as well?
I don't. But okay, can I just answer the one, the peripheral versus central?
Yes, sure.
So in terms of peripheral, I think, you know, the test that I mentioned just now, you have the VAMS, the HIT, that will basically test your vestibular apparatus. So that's a peripheral assessment. Okay, so if you want to look more at central, that's where the VNG comes into the picture, the oculomotor. So that's when you know the difference, like, you know, the pathologist is basically at the peripheral if it's positive for any of the assessment like VAMS or VHIT. But if, let's say, it's normal, it's negative, and when you do oculomotor test, something is positive, for example, maybe like um, something wrong with the gaze test or smooth pursuit or even saccades, that gives you an idea that it's more central related. So you divide those two. So that's why we need to do all the tests together before we could say for sure it's a peripheral problem or it's more central problem. So on my part, if it's everything goes back to the ENT, of course, because we work as a team. But whenever it involves central, that's when we refer them to the neurologist.
Yes, okay, thank you. So we have another question. What kind of vestibular disease is common in children population?
At the moment, it's more if they have global developmental delay, okay, that would be one of the causes for them to have a vestibular problem. And actually, if a child has a hearing impairment, they might also have some form of vestibular issues, which is not captured. We had one child diagnosed with a hearing impairment, but it was a delayed onset hearing impairment. And when we did the vestibular assessment, it was positive, meaning that both sides actually did have a vestibular issue. But being children, because even if they had the problem early, they're able to compensate early as compared to an adult, which is why you don't really notice that, they stagger or anything. But the reality is they do have it, and usually we capture it when they go to school because they have been utilizing visual to compensate for the vestibular dysfunction. When they go to school, they get absolutely tired because it's too much info, to maintain to compensate for your vestibular as well as to perform, your normal visual activities. That's when we realize there's a problem. So in terms of common, it's actually, if you were to ask me, it's GDD as well as hearing impairment.
Okay, I see.
I
So
think
we
I will
move on
take
to, yes,
the
sure.
next question, which is during spontaneous and gaze tests, if the results show up and left beating, do you suggest central or peripheral? I think this one more on how we differentiate the which part of side of lesion. So I think for me, I will go for any assessment that related to the peripheral part, maybe VHIT, VAM, caloric test, maybe if you have to double check if there is any presence of pathology at peripheral. So it can be central, it can be peripheral, it can be both, maybe. Mm.
So whenever you talk about vestibular and equilibrium assessment, there's no like just based on one test. That's because the key thing is actually is like fitting a puzzle. We need to put all the puzzles together. Before we could safely say is it peripheral or central, and whether it's medius or neuritis. So it's no straightforward, meaning that I just do one test or two tests and that's it. You can't, because then you'll be missing some part of the puzzle.
Okay, thank you so much. So we move on to the questions, the coming questions. During spontaneous gaze test, if the results show up and left beating, do you suggest central or peripheral lesion?
I think Shafiq covered that just now, right?
Yep. We
Okay.
already
It's already
covered these
answered.
questions. Yeah.
Yes, so is it possible if we get bilateral absence of OWAM response, or it's actually because of some placement error?
Shafiq?
Okay, I think this one is more on the reliability of the result. Maybe I want to tackle this part first before we talk about any other things, because we want to ensure the result that we get is reliable. So it depends on your system, what indicator that available in your system. So please use all these indicator to ensure that okay, this result is reliable. I mean, the reliability is very good, very accurate. So you believe in your result, and then you can check maybe all the placement of the electrode, for example, even maybe VAM, for example, VAM. I think the placement is quite crucial because you need to make sure the electrode really plays in the, let's say for OVAM, you need to make sure under your underneath the eyes, the muscles right here, and then all the SEM. So SEM also normally I will advise the clinicians to, let's say, just imagine this is the SEM and then use your three fingers. And actually there's one of the research that I read. We recommend to place the electrode here, or here dekat bahagian bawah ni lah instead of paling atas, because kalau atas ni it will contribute a lot of noise compared to yang bahagian bawah, two or third part tu. So that's more on the reliability of the test lah. And then we will check the result. See, and then we, as Miss Darleena mentioned lah, we try to complete the puzzle lah, especially on the result tu lah, yang bilateral absence of ovum response tu.
I think
Okay,
it practically
so
covers it.
yes.
I think it practically covers it. So you can get an absence of bilaterally. Yes, you can, but very, very rare cases. But sometimes to be sure, sometimes is it because of a middle ear problem or something. So you might switch to bone conduction. So again, depends, you know, because like over here, we are able to use bone conduction, but with an amplifier. So if your setup do have it, you might want to change it to that just to be safe that, you know, that the stimulus is being sent. I mean, it's sufficiently high for you to induce the responses.
Yep. Especially for VAM, I think VAM we need very strong stimulus, strong energy. Let's say if you use bone, you need a very strong force level. So that's why we want to make sure there is no conductive contribution from our middle and any conductive element, or maybe any displacement ke, maybe something wrong with the placement. So we need very strong stimulus lah to get very real visible image or better waveform.
But always, you know, before you start off, I mean, if you're not familiar with it, practice on like, you know, subjects, then you get a better idea on how to get the waves. Then you know for sure that it's not an error on the equipment's part or I mean, on the clinician's part. So I think once you've done that, I think you're quite safe to test on patients.
Yep,
okay, I see. Yeah. So move on to the next question, where there's a question asking about Pixalpa is purely to detect BPPV. Is there any condition that can also induce nystagmus during the test? Example, central probe or position of the patient?
Maybe kalau okay, this whole part and BPPV ni actually more on peripheral part. I mean, sorry, say kalau ada contribution from the central part, then I think the nystagmus will be continuous. That's why in the test battery, it's better for the clinician to do gaze or spontaneous nystagmus test first to check any presence of continuous nystagmus. So then they will be this will be the indicator or idea lah during the dissolvite test. Is it because of the change of the position, or is it or other the continuous? I'm not sure it is answer this question or not, but just throw my idea.
Is there any feedback from Ms. Darleena for this question?
They're going to induce nystagmus. Well, any condition can induce nystagmus. It's not necessarily that it can be a central, it can be a peripheral. Nystagmus just indicates there's a problem. It's either in the vestibular or even the central pathway. So it's just that you look whether it's torsional or not, and all those things. So sometimes, for example, like Meniere's disease, you can have nystagmus, but only when you have Meniere's, when we're having that episode. But when you're free of that episode, you won't see the nystagmus. So nystagmus is just an indicator that there's a pathology somewhere. That's how I see it.
Okay, thank you, Shafiq, and also Ms. Darleena. So we have a last question for Ms. Darleena. Like, what is the importance of identifying of subjective versus objective true vertigo? How can it affect the management or outcome?
No, okay, sorry. I think it was kind of misleading. It's not really meaning that it will influence the management. It just indicates that, you know, you need to be sure that, you know, they're actually experiencing true vertigo, whether it's subjective or objective. It doesn't matter. Meaning that because you just need to differentiate whether it's a dizziness or vertigo. So sometimes the reason I ask is that, do you feel that you're self-spinning or the room spinning is just to give us an indicator that whether, you know, you're having a vestibular issue. No, it would not it would not influence the management. It just gives us an info that you're having vertigo. That's about it.
Okay, I see. Thank you so much. So I think we have end our Q&A sessions.
Yep. So actually, I
Yes.
just share some materials that the audience can, I think, can benefit the audience. So actually, on this part, actually is related more on VNG. So this is all the test battery. Let's say, what is the test that included in VNG? How can I deliver the instructions? What the result that you expect? So all this in summary. This is the summary lah. Actually, all the notes. And this is more on the peripheral part for the common peripheral disorder. So let's say if we interested on maybe vestibular neuritis, so we talk about all the tests, VHEAT, VAM, calorie, and all the tests lah. So this is the results that a puzzle lah. Actually, this is the puzzle that we are interested for the peripheral pathology. So actually, I just already share in the chat box. I'm not sure which one. In the chat box lah. I will share in the chat box so the audience can grab the file for your own use. I think that's all for me.
Yeah, thank you so much for sharing. Yes, it's already in the chat box. So if you are interested about the material, so you can always access there. You can download it. And don't worry, we'll also post it later. So just in case you didn't get to download it, we should still share the material to you. So I think, yeah, we have come to the end of the sessions. And I really appreciate it, the sharings. And as a new audiologist, I think definitely I will need to go back and read more about those testings and the results. So it really enlightened me. So probably I can start with some simple bedside. So maybe I can make some referrals. So thank you so much for sharing. So can Liping help us to take a group photo before we end? And also there's one poll. So hopefully you can also give us some feedback, about the sessions. What do you think? So I will launch the poll now. You can also give some comments in the chat box if you think that there's anything that we can improve or any comments about today's sessions. Thank you so much. I can see there are so many responses from the audience. Okay, let's see. What do we have? Okay, thank you so much. We got like quite very high rating for today's session. So hopefully we'll get your continuous
Darleena, boleh clap.
support for the coming sessions. Yes. Okay, so can Liping help us to take a group photo? Is Liping here?
Hi, sure,
Okay,
sure.
audience, can you? Oh, hi, Liping. Yes. Yeah, can you please, everyone, please switch on your camera if you can.
Okay.
Where's Ellen?
Everyone ready? 1, 2, 3.
Yes.
Okay, hold on. Let me save. Then I take the second picture. Okay, hold on. One more. 1, 2, 3. Okay, that's it.
All right, thank you
Yeah,
all.
that's it. Thank you so much. I apologize, there's some delay from my side. Okay, I'm really sorry for that. And hope you have a nice day and see you in the last sessions on next Monday. Goodbye. Feel free to leave the session. Thank you so much.
Okay, semua dah keluar.
Yes. Shafiq, I got delay lah. Saya punya internet tu saya tak dengar apa
Yalah.
yang you jawab tu.
Tapi kan
That's why
tadi
I
kan
repeat.
ada one part dia cakap wow tau. And then wow je wow.
Yeah. Oh my.
Yay, good job to Shafiq, the presenter.
Yeah, thank you.
Yeah.
Good job.
Thanks. Good job, Lichu.
Hey, Shafiq,
Thank you.
I nak tanya, your background too very interesting lah.
Right, macam canggih.
Like that. How do you do it? Very
Okay.
interesting, so cool.
Let me share with you guys. Okay. Do we have more extra time to discuss this? Are you okay?
Yeah. I think it's.
I think
Okay,
everyone left already. Tinggal kita je.
Okay. So basically, I'm using the background. So I changed the background for consider macam I punya slide lah. But my slide is on the background.
Your slide is the background. How do we do that?
Okay, so you can customize your background tau, actually.
Oh.
So to customize the background, you can create dekat dalam PowerPoint. So you just make a PowerPoint macam yang belakang ni lah, my background lah. So actually I open the PDF file and screenshot, and then I put in the slide, and then bila I dah put all the information yang I nak or any content, and then I just show in the presentation mode, so dia akan full screen kan. Then you screenshot again. You screenshot, and then dekat dalam Zoom actually there's options lah. You buka dekat video and then choose a virtual background, and then you can you select background and filter virtual background, and then you add image.
Add image.
Okay, let me share my screen. Okay, so I'm sharing my screen now. Ya ke? I tengah share ke?
Tak nampak. Nampak dah.
Okay. Mana Zoom? Okay, ni choose virtual background kan? You tak boleh nampak the taskbar lah. Ni you nampak tak?
Nampak.
Okay.
Nampak.
So dekat settings ni, you select background and filter, virtual background, and then dekat sini ada add image. So add image. So dekat sini actually I save the picture lah, the image. Macam dalam dekat download ni. So I just that's why I create few image lah, which is actually slide lah actually, but I save in the picture format PNG ke apa something like that. And I select, and then let's say pen lah pen open. So adalah pen.
Okay. But saya nampak dia akan tukar-tukar.
Okay. So that's why you kena arrange the sequence. Kena set the sequence. So macam ni blank kan?
Betul.
So nanti then you kena actually at first sini semua blank, kosong lah. Tak ada all this my slide ni. So I add image ni by sequence. So let's say kalau macam blank ni, macam let's say macam ni home. Actually ni I rename dia jadi home lah. So I add home ni yang first lah, and then follow by phase 1, phase 2, phase 3. So
when you are presenting halfway, you will change